I know you've been burning for this one. Helium and oxygen in the ED. When was the last time anyone pulled out the Heliox? So we may make short shrift of the helium section here. It's been around forever, and it was actually it preceded beta-adrenergic treatment because Heliox has been around longer. So years ago, maybe that's all you had in your armamentarium. We have a little bit better at this point. First question, does it work in asthma? There's a Cochrane review that says no, it in and of itself does not work in asthma. But what's interesting, and I hadn't realized this, is that a number of studies have looked at not just treating with Heliox, but using Heliox as your propellant, essentially, in delivering beta-adrenergic stimulation. So you mix up your albuterol neb, and you're blowing it past using Heliox. Has anyone ever done that? I hadn't done that. I hadn't even heard of doing that. But there are a couple studies. The first one, actually, you don't have. It seems like there was kind of a mix-up in the syllabus. It's referenced. It says the Rodrigo article, but as best I could tell, at least in the packet I got, you didn't have the Rodrigo article. But trust me, I looked up the Rodrigo article, and it indeed is a meta-analysis of a number of studies. I think it was 11 randomized controlled trials in which albuterol was used with either Heliox or oxygen as the propellant in both adults and children. And they actually did considerably better. The number needed to treat to prevent one admission was 9. Small studies, kind of not great methods. None of them are essentially blinded. And why can't you blind these studies? Because have you ever inhaled helium? Everyone who gets helium talks like Mickey Mouse by the time they're done with your Heliox treatment. So I think the only way to blind these studies would be to tell the patient they cannot speak after getting their nebulized treatment. But as best we can tell, asthma may be managed with some improvement with Heliox driving your albuterol nebulization, although the data is not really robust. Does it work in COPD? And the answer is simply no. So I think that's frankly enough said about Heliox and COPD. However you do it, if you try to drive your albuterol or your ipratropium or whatever you're using, there was one study that even used it to try to drive your inhaled steroid. I think they used budesonide. It didn't work. So not something to turn to for your COPD. Abstract number 7, is there any hope? How about infants? Seems kind of an odd study. It was Heliox-driven CPAP, and they used it for a duration of 2 to 14 days. I'm not sure what infant is on CPAP for 2 weeks, but fear not, it didn't work. So that's the Heliox section. In summary, it does seem, at least in what literature we have, to possibly provide some benefit in asthma if you use it as your propellant in giving your usual treatment. In and of itself, it has no effect, and it doesn't seem helpful in COPD. The next topic of this section, oxygen, tool of the devil. I thought that was cute. It talks about multiple studies. It says studies purporting to show harm from oxygen therapy, all virtually observational in nature and deal with longer-term administration than is typical in the ED setting. But I think over the last several years, and it has now even hit the American Heart Association guidelines, that oxygen can be thought of as a drug, and it's not just sort of this benign, showy thing that we do, although it is still treated that way, that almost everybody who hits the ED, it seems, they're getting their IV, and there are several studies that question, why are we putting so many IVs in? and they're on their heart monitor. God knows why. In my view, it just prevents them from getting the urine that I really want them to get. And then they're getting their oxygen slapped on. In Denver, I suspect I'm seeing more hypoxic people than you because the healthiest of us are sitting at around 94%. But even so, it seems like it's just sort of this protocol that everybody, if you've got chest pain, you're getting your oxygen. If you've got belly pain, God knows why, but they're on oxygen as well. And as I said, what we're really starting to, I think, appreciate and conceptualize a little bit more is that oxygen is actually a drug. And like any drug, there are its upsides and its downsides, its side effects. Abstract number 8 talks about oxygen therapy for acute MI, and it's been shown, at least somewhat in animal models, that administration of oxygen can produce vasoconstriction, can increase blood pressure, and decrease coronary flow. So there's at least a theoretical basis of why excess oxygen can be potentially deleterious. And the pulse ox is a very poor indicator of your actual arterial oxygen pressure. So if you're sitting at 98, 99% on your pulse ox, your level of oxygen were you to draw a blood gas can be anywhere from 90s to 300s or 400s. So you can get vastly different levels of oxygen in the blood and not really know it based on your pulse oximetry. And at least, as I said, there's a theoretical concern about that in MI patients. You certainly don't want to be inducing vasoconstriction of the coronary arteries. Abstract number 9, also another MI article. Some evidence to suggest that routine administration of supplemental oxygen after uncomplicated AMI may be associated with potentially harmful reduced coronary flow and cardiac output, increased systemic vascular resistance, and elevated blood pressure. So they looked at 2 studies, randomized trials. They could only find 2, oxygen or just compressed air. And they did find a higher mortality rate, 11.3% versus about 4%. More frequent VTAC, larger infarct size, certainly not the best, largest studies, but the accumulation of evidence, again, is suggesting that oxygen in the setting of MI, when pretty much everybody gets their nasal cannula oxygen, may be harmful. There's an article next, number 10, how about stroke? Does routine oxygen supplementation in patients with acute stroke improve outcome? Again, only 2 small randomized controlled trials have been found, one sort of quasi-randomized 2. What evidence there is suggests that, as I said, maybe in the more severe strokes you could get slight improvement, but milder strokes, which is the majority of patients, it might make things worse. So I think the take-home for oxygen is enough but not too much. So some of these articles have talked about shooting for a pulse oximetry of 94%, 95%, but not beyond that. The AHA guidelines now talk about only administer oxygen to people who are in need of oxygen in that their pulse oximetry is below 90% or they're at risk for becoming hypoxic. I'm not sure how you're predicting the future risk, but they're now on board with saying if they're not hypoxic, you are certainly doing no benefit by giving them supplemental oxygen. And we have some worrisome, mostly observational data that you might be doing harm. So accomplishing that in the ED, going in and ripping the oxygen off people's faces when the nurses have just put it on, I think would be our next challenge. But it's probably one that's worth trying to educate your residents, your nursing staff that, if they're not hypoxic, they really probably don't need the oxygen. Anybody starting to do that in their practice? So I think it's catching on, and I suspect it'll gradually build up steam, and it'll just make more sense when we do that. It never did make a whole lot of sense to me. Why are we slapping the oxygen on when they're at 96% sat? Did you have a comment?
I'm just curious what you think of frequently we get patients coming in who are, they've got obviously cardiac risk factors and all, chest pain and stuff. And the first thing is, I feel short of breath. And, I don't even do SATs, in other words, routinely, reflexly, possibly wrong at this point. So, like, slap oxygen on it, using that, basically comes out to be a SAT like 95, 96%. If they feel short of breath, they're having, cardiac pain.
I think the data is weak enough that if even it's only a placebo effect, if shortness of breath is one of their complaints, I certainly don't have any issues with that. And I think, as we've all seen, of course, if you're blowing down your PCO2 enough in order to compensate for getting a higher oxygen reading, then maybe just giving them some supplemental oxygen will indeed be helpful. For those of us who try to make everybody, as they say, euboxic, all the vital signs have to be good when they leave, and the nurse says, well, and this happens in Denver again a lot, the pulse ox is 88%. And it's like, oh, I can fix that. It's like, take a couple deep breaths and say, there it's 92. We're good to go. So, I think that's frankly enough said about oxygen. I guess aside from the final topic, what about oxygen and neonatal resuscitation? And they have been on board with this for far longer than we have. Abstract number 14, more than 600 infants found that infants resuscitated with room air rather than 100% oxygen tended to have a lower neonatal mortality rate, odds ratio of about 0.7, significantly higher APGAR scores at 5 minutes, no neurodevelopmental differences. So their standard protocols now for resuscitation of a newborn is that they resuscitate with room air. They're not adding supplemental oxygen. And I think maybe in the pediatric literature, it is a little bit more robust, and we're now starting to apply it to the larger pediatric population, otherwise known as adults. If, I guess, kids can be small adults, we can be large kids. Yeah?
I remember that one of the first shocks of, I'm an old guy now, but I did my training at University of Cincinnati, so we did our peds at Children's Hospital there, which has a pretty good background. And one of the first things that caught me was whenever I would call the pediatricians up about a kid, an asthmatic, and he had a SAT of 87 or 88%, I'd be real nervous. They were always like, well, that's not a problem. As long as it's 88, they always have a lower threshold.
Yeah.
Say a higher threshold for hypoxemia. And the kids that I found experience did a lot better with lower numbers.
Yeah, there's one study, I don't know if it's in our syllabus or not, that looked at blinding the physicians to the pulse ox value in kids just like that, like the RSV kid. And we treat them very differently with similar outcomes, but if we know the pulse ox, we get very hung up on that oftentimes. Given that this was kind of a thin topic, I thought I would hijack the rest of it and talk about something that I think may be of more interest and is not well understood, at least in my experience, and that's capnography in the ED. I figured it's sort of a gas-related thing. We've talked about oxygen and helium. And capnography, of course, is the measurement of end-tidal CO2. And one of the triggers for this is I was listening to this month's EM Rap Talk, and they were talking about use of capnography in procedural sedation, and is it valuable, is it not valuable? And one of the commentators said, well, not only do I like to see the waveform, but I like to measure, I like to follow the actual number, and then that tells me whether the PCO2 is going up. And that's wrong. And it bothered me when I heard that on EM Rap, that they're just teaching the wrong thing, and I think that's a common mistake, that we think end-tidal CO2 is PaCO2, P arterial CO2. And it is probably for everybody here. So we're all generally healthy, we're breathing normally, And our end-tidal CO2 reflects our arterial CO2. But that is not the case with a lot of the patients whom we care for. And I think for somebody, like I said, on EMRAP to be teaching the wrong thing is putting us in a difficult situation if that's how we're thinking about it. And I know one of our chief residents made this mistake a couple of years ago, that he was watching a COPDer by measuring the end-tidal CO2. And he was saying, oh, the end-tidal CO2 value is fine, as the guy went into a near apneic arrest, because he was somehow expecting that, well, if the PA CO2 is building up in the blood, the end-tidal CO2 level will go up. So I wanted to clarify that because I think that's a common misconception. Basically, end-tidal CO2 is a reflection of two things. One, it's a reflection of the arterial CO2 partial pressure, but it's also then a reflection of delivering that to the lungs and the dead space in the lungs. So one thing you need to know, of course, is that there's essentially no CO2 in the air. So as you breathe your air in and out, you're getting no CO2. So any CO2 that you're measuring with your end-tidal CO2 indicator is coming from the patient. So part of the problem, like for instance in the procedural sedation realm, if you are making a person nearly apneic, so that their ventilatory rate is going down, their tidal volume is going down, then you're starting to get into the area where you're just moving room air up and down a little bit. So if you could imagine, rather than taking deep breaths that pull the oxygen down into your alveoli, you're taking these tiny little shallow breaths that are basically just going in your mouth, maybe upper part of your airway and out again. You're essentially down to breathing ambient air. And the ambient air PCO2, I just said, is 0. So the less that you're ventilating, the lower your PCO2 may be getting, while your PaCO2 is getting higher. So you're getting a direct opposite effect. In the setting of cardiac arrest, when you're ventilating a patient, so you're blowing the air in and out, the PaCO2, I'm sorry, your end-tidal CO2 is an entire reflection of your cardiac output. So that's another concept that I think it's a little hard for people to think about. But in 2010, the AHA came out with a level 1 recommendation that in the setting of CPR, cardiac arrest, we measure end-tidal CO2, and anybody who is then on a ventilator, we're measuring their end-tidal CO2 to watch for changes. So again, if you think about a patient in cardiac arrest, and all the CO2 that their body is generating, if you have no circulation, you're not getting any of that to your lungs. As you do CPR, you're getting whatever you're getting off to your lungs, and then because you're ventilating the person, any end-tidal CO2 that you're getting is a direct reflection of cardiac output. So that's why end-tidal CO2 is one way of measuring the adequacy of your CPR. So if you're doing good CPR and you're ventilating the patient, you'll get some degree of end-tidal CO2. And it's also a way of monitoring whether the patient's having return of spontaneous circulation. So if you've got a fairly crappy end-tidal CO2 reading, it's 6, it's 8, then that means you're just not getting any cardiac output. And then if suddenly it goes up to 20, it means that your cardiac output has picked up and you've got ROSC, you've got return of spontaneous circulation. So that's why many people say the best measure of return of spontaneous circulation is your end-tidal CO2. So I had a couple clinical scenarios that go along with this concept, and I'll present them, and you can tell me what you think. So another thing to point out is that the sicker the patient, so they've got COPD, they've got congestive heart failure, they effectively have more dead space in their lungs. So dead space is not just your airways, but it's also your alveoli that are not getting circulation to. It's that VQ mismatch. So every time you have a patient who's got COPD and congestive heart failure, a good portion of their alveoli are not being properly fed the blood, so you can't get the CO2 into the alveoli in order to get out of the circulation. So one of the take-homes is that your end-tidal CO2 is never higher than your PA CO2. And your end-tidal CO2 is not reflective in the sick patient of your PA CO2. So here's my scenario. A patient with a history of COPD, CHF comes to the ED with increased shortness of breath and work of breathing, and their end-tidal CO2 is 20. So what does that tell you about their arterial PCO2? So could it be 15? Could it be 25? Could it be 60? Could it be 80? Can't be 15. Right. So it could be any of the others. So that end-tidal CO2 level of 20 could be a PA CO2 of 25 or 60 or 80. And that was the mistake, as I mentioned, this chief resident we had a few years ago made, that the patient, when somebody decided to get a blood gas, the PCO2 was like 80, while the end-tidal CO2 was 20, because they had a huge amount of dead space. They were essentially just mixing the air from the circulation with ambient air, and it went down, as it will go down. So again, the end-tidal CO2 is not a reflection of your PA CO2 in a sick patient. The final clinical scenario is you've just intubated a patient with a bad pneumonia. The end-tidal CO2 reads 65. So you should, A, get a blood gas to confirm that, B, increase your FiO2, C, increase tidal volume, D, increase ventilatory rate, or E, get the patient up to the ICU as quickly as you can. So what do we got? Yeah, so what this reflects is, as I said, again, your end-tidal CO2 is never going to be never going to be lower than your PA CO2. So if it's 65, you know that your PA CO2 is at least 65. It could be 80, it could be 90. So if your end-tidal is, again, 65, then you know that your PA CO2 is way too high. And so you don't need a blood gas to confirm that. It could be with an end-tidal CO2 of, what did I say, 60, 65. It could be 80, it could be 120. You know it's not lower than 65. So in that situation, you have to ventilate the patient better. And of course, you can ventilate in one of two ways. You either increase your ventilatory rate, or you increase your ventilatory volume, or you do both. But when you're in that situation, your end-tidal is high, you got to do better by ventilation. So is that clear? Because I think it's a very common misconception that the number somehow reflects, even in sick people, the arterial CO2 level. And that's why in the setting of something like procedural sedation, what I use it for, and I think really the only value, is the patient breathing? So you get this waveform, and I don't really care what the number is, but it'll tell me, is the patient ventilating? Are they breathing? Are they moving air at all? And the number doesn't help me in determining how well they're ventilating.